We're now joined by other panelists that are going to speak to us about value-based payments and provider sustainability. And I am going to introduce Ashlen Strong from Healthcare Management Associates to facilitate the conversation. Ashlen?
Good morning. We are so excited to be here with you and support CCO Oregon this morning. As Samantha mentioned, I'm Ashlen Strong, a senior consultant in the Portland office of Health Management Associates. HMA has more than 250 expert healthcare consultants in 22 offices across the United States, and we've done a vast amount of work in the value-based payment arena, assisting government agencies, payers, and providers. In Oregon, the HMA team has worked with many provider organizations to complete value-based payment readiness assessments and help them prepare for entering into value-based payment arrangements. If you want to learn more about value-based payment provider readiness, HMA is hosting a free webinar in partnership with Health EC on September 15th from 11 to 11:30. You can also, of course, reach out to any of us at any time. Today, our goals for this conversation are to share the good work CCOs are doing in the value-based payment space, identify opportunities and challenges with value-based payment adoption and expansion, discuss provider sustainability and adoption of value-based payment arrangements. And our esteemed panel includes Jenn Welander, Chief Financial Officer from St. Charles Health, Mary Kjemperud, Vice President for Network and Clinical Support at CareOregon, Peter McGarry, Vice President of Provider Networks at PacificSource, Chris Hummer, Chief Executive Officer of Trillium Community Health Plan, and Patrick Allen, Director of the Oregon Health Authority. First, I'm going to invite each panelist to briefly introduce themselves and describe how their organizations are currently engaging with value-based payments. Then this will be followed by a Q&A with the panel. So let's begin by defining what we mean by value-based payment and hear from Pat Allen, Director of the Oregon Health Authority. Pat?
Great, thanks, Ashlen. Again, I'm Patrick Allen, Director of the Oregon Health Authority. I like to say that before February 28th, when we had our first COVID diagnosis, I've been at the agency for 2.5 years and about 10 years since February 28th, when we had our first coronavirus diagnosis. So about 3 years actually this month I've been at OHA. So let me quickly talk about some definitional ideas around value-based payments. If we could pull up the slide. What's the problem? Well, the problem is one that we've been talking about my entire working career: healthcare costs and the fact that they've been going up faster than the economy for going on 40 years. Healthcare spending continues to rise. The most recent US data showed that costs went up about 4.6% in 2018, which was more than double the rate of increase of the size of the economy. And so every year, more and more of our dollars go to healthcare. I remember first paying attention to this number in the late 80s when it was about 9% of gross domestic product that went to healthcare, and now it's about 19%. And now Oregon, which used to be somewhat below the national average of healthcare spending, has really caught up so that we're at that same US mean average. And then the burden of healthcare is high and increasing on Oregon families. In 2016, Oregon premiums were almost a third of a family's total income, recognizing that the family itself doesn't always pay that premium, but it's a significant burden. All right, let's go to the next slide. Many Oregonians are delaying care because of the costs. And data shows that communities of color can be more likely to be impacted by high healthcare costs. Oregonians who are 2 or more races, or Native Hawaiian or Pacific Islander, are more likely to have delayed any type of care in the past year because of costs, over 20%, compared to 15.9% of white Oregonians and 12.9% of Asian Oregonians. Let's go ahead and go to the next slide. Coronavirus, it's not quite all I think about right now, but it's a lot of what I think about right now. And we know that coronavirus is going to have an effect on healthcare costs in 2020 and 2021. We just don't know how much or what direction. Costs in some thinking could go up due to the actual costs of treating coronavirus. Costs could go down because so much healthcare has been deferred during the crisis. We don't know how much has been deferred, but will come back later. And so the spending will even itself out over the intermediate term. Or has some of that deferred spending, is that spending that has simply gone away and won't come back? Or will it be replaced by more expensive healthcare because it was important preventive care. We just really don't understand yet the effects of coronavirus. We do understand the effect on the economy, which has been dire, and so we're faced with a pretty significant budget cliff. The Joint Economic and Revenue Forecast predicts a $4.4 billion shortfall in the 21-23 biennium, and so that's a cataclysmic level of cut, exceeding even what we had to deal with during the 2008-9 recession. Next slide, please. So value-based payments basically are the idea of paying providers for value, not volume. And this becomes a key strategy for us in trying to manage these costs. They have to have a linked quality, and they have to pay providers for the value instead of the volume of care delivered. Fee for service, we know, is the one system that does not work in trying to control costs. It hasn't worked for 40 years that we've been using it, and so we need to move to value-based systems. Providers need to be rewarded for a combination of high quality care, positive member health outcomes, and cost savings. And so what we'll find is a mix of quality as well as risk in the type of a payment that needs to occur. Many value-based models give providers flexibility with regard to care delivery, allowing them to comprehensively meet patient needs. Ongoing prospective payment, which can manage variations in visit volume due to, for instance, COVID-19. The system can be more flexible and can and should incent the right kinds of provider and patient behavior. Let's go to the next to last slide. In CCO 2.0, providers or CCOs are going to have 3 requirements around value-based payments. First, they have to pay each of their contracted patient-centered primary care homes, PCPCHs, on a they have to provide them a per member per month payment, which serves as a foundational payment for infrastructure and operations. Second, they have to achieve an annual value-based payment target. In other words, the percentage of their total spend that has to be in the form of a VBP to their provider portfolio overall. And it must be a pay for performance kind of a VBP model. Over the 5 years of the CCO 2.0 contract, the targets are 20%, 35%, 50%, 60%, finally going up to 70% of the spend. We don't get into trying to detail which 70% does that spend need to be aimed at. It leaves 30% for places where a value-based structure just isn't really appropriate or feasible or can't get there. That's a fair amount of leeway, but the idea really is to drive the system hard toward value-based payments. The VBP's third requirement is that they have to be done in 5 care delivery areas: hospitals, maternity care, behavioral health care, oral health, and children's health care. Let's go to the last slide. Really critical to this is the idea that we're trying to push toward value-based payments, not just in the Medicaid space through CCOs, but across a variety of payers that we've got some degree of control or leverage with. And so we're working to expand this to PEB and OEB, who have now adopted these same value-based payment targets, including being at 70% by 2024. They're also aligning health plan quality measurement initiatives with the approaches that we use to measure and incentivize CCO quality payments. So really trying to answer this issue that providers bring up a lot, which is I got 1 million different payment structures for 1 million different payers, and it's really confusing and complicated. We're trying to do what we can to align that and create a more uniform playing field. Then the last thing I'll touch on quickly, the Healthcare Cost Growth Target Implementation Committee, Senate Bill 889, is developing principles for accelerating the adoption of advanced value-based payment models in the commercial market. And we can talk a little bit more about that later on. So hopefully I kept reasonably close to my appointed 5 minutes. Ashlen?
You did. Thank you so much, Pat. Let's start with introductions with Peter McGarry.
Let's ask the most important question first. Can you hear me okay? Excellent. My name is Peter McGarry. I'm the Vice President of Provider Network with PacificSource Health Plans. I've been in this role with the company for the past 12 years. PacificSource operates 4 CCOs across Oregon, Central Oregon, Columbia Gorge, the Marion Polk area, and one of the CCOs in the Lane County area. We also have some significant Medicaid membership in the Portland area under a contract with HealthShare of Oregon. Overall, we cover 250,000 lives in the state of Oregon. Thank you.
Thank you. Next, Chris Hummer with Trillium.
Yeah, can you hear me?
Yes.
All right. Thanks for the opportunity to be with y'all. I've been here in Oregon a little over a year, and prior to that, the last 25 years on the provider side, managing clinics and hospitals, most recently with Atrium Health, which is a public not-for-profit based in Charlotte, North Carolina. We had responsibility for hospitals as well as our emergency services service line. You know, one of the attractions for me being in Oregon is the CCO model and the coordination that's required. It's long overdue, and certainly to Director Allen's point, I hope that we continue along this to also influence other payers and folks interested in driving value for healthcare. Trillium has been around about 20 years as you know, in taking OHP patients as members, and certainly with the responsibility and privilege of expanding into the Tri-County area, look forward to continuing to collaborate with HealthShare and others to you know, improve the health status of those we have the privilege to serve.
Great, thank you. And now Mary.
Good morning, and thank you for inviting me today. Ashlen has already shared. My name is Mary Kjemperud, and I'm the Vice President of Network and Clinical Support at CareOregon. And I'm always happy to share our views with anyone who wants to listen. So CareOregon is an Oregon nonprofit that has been serving Oregon health plan members for over 25 years. Currently, we have approximately 400,000 OHP members statewide. We are a founding member of HealthShare of Oregon, one of the main CCOs that contracts to manage a benefit in the Portland metro area. CareOregon manages behavioral health benefits for HealthShare's 300,000 members and physical health benefits for approximately 200,000 of those members, and dental health benefits for about 7,000 of those members. In addition, CareOregon manages the OHP benefit for about 45,000 members in Jackson County through our ownership of Jackson Care Connect, and 30,000 members in the Clatsop, Columbia, and Tillamook County area through our ownership in Columbia Pacific CCO. And then CareOregon also manages care coordination for approximately 18,000 fee-for-service based tribal members across the state. And, you know, while we're all experiencing the impact of the COVID-19 impact, I think that's highlighted for us again, the need to move away from the fee-for-service payment structure. And our experiences over the last 5+ years in the value-based payment arena has us primed and ready to move forward at a probably faster pace than we had planned.
Great, thanks. And finally, our provider expert, Jenn.
Great, thank you. Thank you for having me here today. I'm Jenn Welander. I'm the CFO of St. Charles Health System. St. Charles serves Central Oregon with 4 hospitals and 250 provider medical group, and I've had the opportunity to be with the health system for 11 years now. We currently participate in a variety of value-based arrangements, from a Medicare ACO, Accountable Care Organization. We accept up and downside risk with certain Medicare Advantage contracts, and then certainly with our CCO, who currently serves over 57,000 lives in our area, we have a very integrated value-based arrangement with both physical and behavioral health providers across the region. All of our primary care level providers are capitated, and the hospital also accepts capitation as well for the vast majority of all services provided by St. Charles. We as a community of providers collaborate on a shared set of quality metrics, and we share in risk withholds from both capitation and then the global budget surpluses. And we combine our performance and look at it holistically. St. Charles sees the work we've done with the Central Oregon CCO as fundamental to helping transform our business, and we have a very strong desire to accelerate our acceptance of value-based arrangements across all lines of business.
Great, thank you so much. I'm excited to hear what you all have to say through this panel discussion. So our first question, or sort of topic of questions, is around regional differences in value-based payment. So I'd like to start with Chris Hummer. Trillium brings near nationwide Medicaid managed care experience to Oregon through its relationship with Centene. What lessons in value-based payment have you learned from those experiences? And specifically, what have you learned about preparing providers for accepting more risk?
Yeah, sure. Thank you for that. We do have a great deal of experience in value-based models with Centene. We're actually in 29 states and government-sponsored healthcare. So there is a lot of lessons learned out there, and just in my own experience on the provider side for 25 of those. Clearly, to Director Allen's point, we want an affordable and sustainable healthcare system, so we've got to move from volume to value, obviously. And when I think of some of the lessons learned, one of the top ones is that this is very difficult, hard work that requires actually doing things differently. It's going to take a lot more behavioral and structural changes for patients, providers, managed care entities, as well as CCOs, if we're going to make real progress. And one of the things is that most important is really getting people to agree on what really drives value. And Director Allen commented on this one as well. There are a lot of opinions about what value is, and we need to continue to push for more solidarity around what is really most important. Otherwise, you're going to have a lot of effort diluted and impact not met when you engage in these things. Once you agree on what is most important, you've got to have an incentive system around value with providers. Moving from volume to value is a pacing issue, to be sure. You have to realize you're basically changing a compensation system for a lot of people. We also got to better engage patients. We got to meet them where they are. Our healthcare system is certainly not as convenient or as accessible as it should be, and so continuing to have investments in mobile medicine, telehealth, case management are necessary if we're really going to do a better job of achieving better outcomes. And then certainly dealing with vulnerable populations, that is something that requires us to continue to go deeper and attack social determinants, because if we don't do that, we're not going to get to the root cause of what really we're trying to treat in our healthcare system. And then finally, patients. This, again, is hard work that isn't going to reveal itself overnight. And I think everybody has to have an expectation of that. With regards to your second kind of question there on preparing providers, I think it's about understanding their mindset. You have to understand that there's going to be trepidation about assuming risk in value-based arrangements. Again, you're basically changing compensation, and that makes people uneasy. Often see these things as unfunded mandates, oftentimes from the provider side. They've got a lot of competing priorities, and they've got to make sure that those are funded. We've got to make sure that providers know which members are responsible for it. They actually have actionable data to be able to influence the care process. And then it's always going to take even more collaboration than we see today, which leads to innovation in care settings. And we've been proud to do that down in the Eugene area over the years. We've got a lot of great examples where we've worked with our providers on reverse integration models with oral and dental and behavioral health. So, that's my answer to your question.
Great, thank you. Mary, similarly, CareOregon's network spans both rural and urban markets, as you mentioned. Have you noted differences in working with providers or contracting in the two different types of communities?
Yeah, we certainly have. And as I described, we do cover lives in several counties throughout the state, and definitely have seen the need to make adjustments in there. But we are, generally striving to have the core strategies and methodologies and objectives aligned across the CCO regions. It's been, clear to us that we've had to adjust specific needs of the provider partners within the communities that we serve. And we know that we have to respond to those needs that are, nimble and accurate enough to be able to do so. Some of the variables that we've seen and noticed in the differences between the geographies really is just simply the availability of providers, whether it's hospitals or specialists or whatever. It's just there's differences of the providers that are available. Membership size, obviously in the previous discussion too, that the membership size, it deals with the provider's ability to accept risk and take risk. I mean, they have to have, a large enough population to be able to kind of spread that. Resource availability is another thing, drives different. And then also, as we discussed too, member disparity and making sure the equity lens is applied to things makes, is different between the community. So Columbia Pacific CCO, for example, it is the 3 counties that we talked about, and a very unique provider up in those 3 counties. And so, I mean, one of the counties actually has no hospital. Access to specialty services often involves an EMT transport of some kind. So Columbia Pacific has created a unique county-based risk model that we've had in place for over 4 years now, and have really learned a lot of interesting and exciting things in that model. But really, at its core, it allows the county providers to work collectively together toward common cost and quality goals. It kind of addresses the membership size issue we have, but as they work together collectively for the county-based membership. It also is bringing the communities together. We've seen some really powerful relationships built and kind of strengthening the whole of the delivery system in the counties. And then we're also providing a technical and organizational support for those providers that's really building sustainability in the future and the ability to take value-based payment models going forward. But there's definitely a few challenges with the diversity, but we think that our statewide network and the unique is allowing us to see opportunities to build from there.
Great. I think the community network, community risk model is a great transition to our next topic, which is about expanding to other payer markets. So I'm going to turn to Peter and ask PacificSource, as a payer organization, you have multiple lines of business, including Medicaid. Medicaid now covers almost 30% of Oregonians, but we can't expect 30% of the market to drive payment reforms or care delivery, sort of as both Mary and Chris mentioned regarding the member size issue. So how do we expand value-based payments and perhaps lessons learned with the Oregon Health Plan to other payers and commercial markets?
Yeah, thanks. To that, I would say, our experience at PacificSource is we've had value-based payment arrangements for a long time in both the commercial and the Medicare markets that have been prior to or alongside what we've had in the Medicaid space. And a lot of those arrangements sort of come from the variability that's out there in the provider world. Some providers are very comfortable with value-based payment arrangements, downside risk, elements of population health, and they've been in those arrangements for a long time. But some providers have not. Some remain worried about those, maybe not set up for success in those, and it's definitely more of a challenge to sort of see eye to eye on how a value-based payment arrangement might be put in place. I would say just things that have been really helpful in our experience over a long time in Central Oregon and Columbia Gorge particularly, those arrangements, how they've proven successful over time has sort of proven the concept. And we have seen providers get more interested in value-based payment models across all lines of business because Medicaid has been successful. To see some providers say, I don't want to see any Medicaid members 5 years ago, and then say, how do I get more later, has been a really wonderful phenomenon to see. A couple of things that are really important, though. There has to be enough lives in the model for the provider to be able to take the risk. So there's got to be a threshold where if you only have a couple hundred lives, an arrangement might not make sense. And the second thing is there's a lot of variability in the provider's capability, their leadership, their ability to execute on strategies. It's really important in this space. We've seen some providers not be set up well for value-based and not be as successful. So I just think the variability of providers to be able to act on strategies to be successful in value-based is just very critical component.
Great. Well, speaking of success in Central Oregon, Jen, we know that you have developed a strong value-based payment arrangement for the OHP population in your region. As a hospital system, you're obviously contracting with more than just Medicaid payers in the community. So how do you manage the administrative and operational burden associated with multiple value-based payment arrangements from different payers and lines of business?
So I would start by saying that we're still very much in a learning phase. Because of the inconsistencies between the different contract models, like you called out, value-based, we still have many fee-for-service arrangements. It really does make it difficult to link financial performance to our method of care delivery across the whole health system. So strategically, St. Charles views it as an absolute imperative that we transition the majority, and we've set a bold target to say 75% of our revenue to value-based arrangements over the next 3 to 5 years. We have to get to that tipping point where that would allow us to align our operations with how we fund and finance a health system. So we have made and continue to make and need to make more investments in technology and new teams to do the work differently. We need to be able to see the member in its entirety and partner with our payer partners to do that. And I would say, as I step back, there's a few things that I think about. We have to push ourselves to try things that we've never done before and we're uncomfortable with, and we have to be comfortable failing. And that's not something that we all want to do regularly. We have to listen to our patients and design the care around what they actually need and want, not what we think they need and want. And we have to collaborate with everyone in the healthcare ecosystem, folks that you may have traditionally seen as a competitor. If you're going to have value-based arrangements, it's not that we each have them, we all have to share in them. And I guess lastly for us, we have to agree to not accept the fact that we don't provide the value we need to, and that we on the provider side need to change. And those are hard things that we just have to continue to work on.
Wow, thank you. Pat, hearing what's been shared on the point of expanding value-based payment to other markets and managing the administrative expectations for providers, and based on what you mentioned about your experience with Senate Bill 889, how can the OHA develop policy or support to further adoption and alignment of value-based payments across various payers?
Yeah, thanks, Ashlen. I think a part of what I touched on is really aimed right at that, of trying to align the Public Employee Benefits Board, the Educator Benefits Board, and the commercial market at the same general targets and the same systems. If you add all those lives together, that's about almost 40% of lives in Oregon across those 4 markets. And we now have PEB and OEB, as I mentioned before, on the same system as same targets as the Oregon Health Plan. And the individual market through the health insurance marketplace has got the ability through active purchaser contracting to begin exploring the same notion of using those same targets. And that market, of course, is much more stable than it was 3 or 4 years ago when we might have first started trying to have those conversations. So I think that's the first thing. I think the second thing is, as Peter says, we're beginning to really have a pretty good idea of what works and what doesn't work. And so while we've tried to provide some fairly broad guidance to CCOs, particularly about how to construct value-based payments, we haven't really gotten into engineering details. I think one of the things that we can start exploring particularly is to look for VBPs that have good experience doing some of that engineering work, so the different payers aren't calculating the same thing in slightly different ways that drive providers insane, trying to figure out all those different systems. And then the third thing, as you touched on, the Senate Bill 889 committee is really focusing on what is a cost constraint target in the state, and then what are the best strategies to try to move those forward. And we think in particular there we can get more leverage with the 60% of payers that are outside the system, in particular self-insured payers who insure 1 in 4 lives in the state, are completely unregulated by any state insurance requirements, where we don't sort of ordinarily have a lot of the leverage that we have elsewhere. But we think what we can do is offer a value proposition to them to try to line up on the same kinds of standards.
Great. Well, speaking of provider sustainability, we're going to turn now to the topic of provider sustainability, COVID-19, and value-based payments. So I want to turn back to Chris here and ask, how did your existing value-based payment arrangements help to sustain your provider network when patient volume and utilization decreased during the COVID-19 stay-at-home orders? What adjustments to contracts, if any, have you made due to COVID?
Yeah, no, thank you. Yeah, we have, we've had value-based agreements for a while. We don't have a tremendous number of those. Most of our contracts are blended fee for service. We do often have the PCPH per member per month payments in there. Now, those certainly assisted with some cash flow for some practices and providers. What we've really done, I think, very well over the years is had a very strong alignment with regards to the quality bonus pool, and certainly with OHA's instincts early on in the pandemic, allowing those to be released early and get those out directly to providers very quickly. And then our board has really been a great partner in recognizing that there are going to be people even outside of our network as well, not just providers, but community partners that need our help. And so we've reserved 20% of this year's quality bonus pool every month for people to apply for those funds in need of assistance. And so we've been able to prop up folks through those dollars as well.
Great. Peter, do you have anything to add about how value-based payment helped to sustain your provider network during the pandemic?
Yeah, I generally have to say any providers that were on a capitated payment methodology, we're really happy that they were on that methodology. I would maybe ask Jenn to either confirm or deny that statement, but we were definitely hearing that providers felt like that supported them tremendously. In fact, we had a bit of an uptick of providers saying, hey, I want to be capitated and can we do that thing and what have you. What we did instead of rushing into new capitation arrangements is largely did some things that additionally financially supported providers. So one of those was a steady stream of stability payments. Providers that were on fee-for-service that saw a big downturn in their utilization, we provided some sort of sustaining funds for those providers to make sure that when the pandemic is over or lessening, they're still around and still able to provide care for members. Second thing we did is we suspended all claims or capitation withholds, so the downside risk components of our arrangements. We basically swept them away and said those dollars are much more useful in the provider's hands in this critical time rather than us holding on for the purpose of a settlement. So that was the second thing we did, and I think providers really appreciate it.
Great, thanks. Now we're going to turn to behavioral and oral health integration. So I'll start with Mary here. We know that CCOs, including CareOregons, have made significant progress in value-based payment for oral health and specialty care like behavioral health. How have you used value-based payment strategies to incentivize behavioral health and oral health integration at the provider level? And what challenges remain?
Yeah, so CareOregon has focused a lot of time and resources into the ongoing development and implementation of these in both the oral and behavioral health services space. And we're always engaging with our providers and our members in trying to, help develop the models that are going to provide benefit to the entire system. So some of the current, in behavioral health, some of the current models that we have up and running include models that are working to align the members' need for reliable access to quality services, and then the provider's need for a predictable funding stream. And especially in behavioral health, that often they don't necessarily work together. And so we've had a lot of experience in trying to design models that help answer both of those questions. So a few of the things we have some mental health case rates. We created this corridor, so we have some, skin in the game with the providers. We have the mental health composite score that comprises about 7 outcome metrics and, creates a score and can earn bonuses based on their performance. And again, aligning the quality component, but also bringing together that financial funding stream that's needed. Also, we have some base rates have performance bonuses in specific specialties, because in the behavioral space we do have a lot of need for specific providers. So things like residential treatment, then some general access measures, and then providers that use feedback-informed treatment and participate in that. So, trying to really look at models that provide that quality. Some of the things that we have in development and something that we're very excited about right now is with the Alliance for Culturally Specific Providers. Really, that group is collectively working together to help address the systemic health and racial disparities that are very in the behavioral health world. The goal is that we kind of co-design something through the collaboration with all the providers, and with the focus being on the provider and the member voice experience. That the goal of that is to get sustainable payment model in place that's going to, provide the needed services for that population. We also have work in the psychiatric emergency services and patient psychiatric services model. We're working with Unity and others and trying to develop something there. Also, a substance use disorder composite score concept like we have in the behavioral health space. Then on the oral health side, we've been working on it. We have an APM with our contracted dental providers that creates a dental home for the members. And this allows our dental partners to shift their focus more to a population health basis rather than just dealing with the engaged members. So really helping to move that and incentivize performance beyond the typical claim payment component. We also have done in the dental space some integration initiative funding where we've working with the providers and if they identify partners in the physical or behavioral health space that they're working with, we've provided some kind of foundational funding for them to work together to develop that relationship funding model. And so we've provided a faculty, and we've got year-long learning collaboratives, and the ultimate goal is to have a developed toolkit for those dental providers to help them move into the BBP space with more confidence. And then we've always had, in our physical health alternative payment models, we've had oral health metrics in that area, again, to just keep the focus in the oral health space. A few things we have in development there is an oral health prenatal strategy and trying to work with our maternal child youth leadership in developing something in that space. And then really we want to strengthen that dental home population health program focus in the dental space. So some of the challenges that we see as everyone and others have described as well, that we really are building a plane in mid-flight. We have to keep things going. We have to stay in the air while we're kind of rebuilding the engine. And then, the challenge that always exists too is aligning with the current billing and payment infrastructure so that we still support the rate development, so that we are ensuring that we get the continual funding we need. As others have described too, as we've talked, provider readiness and aptitude is, it varies. And in some of the space in with the oral and behavioral health providers, it may be even more. Leadership engagement have many competing priorities right now. And just keeping focus on oral health, behavioral health in the midst of the already strange primary care environment is always a challenge. But I'd say we are primed and ready to continue our deployment and strengthen our focus in the VBP in support of our members in care areas.
Great. That's a lot of information about that topic. So I'm excited to hear that CCOs are doing so much work in that space. I think our final topic is really important, so I'm going to try to skip ahead for our last question here. And this topic is about health equity incentives and value-based payment. And I want to turn to Peter and say, we've seen the impact of health and healthcare disparities on full display during the pandemic over the last several months. How have you used value-based payment strategies to incentivize care and services that strive to eliminate disparities for communities most at risk for inequities?
Yeah, I'd say the primary way we do that is through our value-based payment models, which, whether you're talking about capitation payment or you're talking about the setting of a healthcare budget, varies dollars that are either paid or set in that budget depending on the benefit category of the member. So, for example, if it's members in the dual eligible categories or members in some of the higher cost categories, there's more dollars associated with those members, and those dollars get paid out to the providers through those two mechanisms, cap and healthcare budget. And that does some things in sort of making sure that you aren't sort of building in inequities to your models, but it's somewhat a blunt tool, I must admit, because it doesn't really take into account a lot of the next level work that you can do in that space. Some of the things that we're doing is identifying a lot of trends by subcategories in terms of the geography that the members are in, the ethnicity of the member, medical complexity. And so we're gathering that information to make both budget setting and capitation more granular, so that we're paying for some things that are in the inequity space. So, hey, if we're seeing some opportunities with providers, we've got opportunities to work with them and say, look, with this ethnicity or with this degree of medical complexity, there's something that's not taking place. So how can we work together to make that happen? I think those things are not in place yet, but we're putting the tools in place to be able to get there and sort of take our payment methodologies to the next level, because just doing it by benefit category, probably not doing enough.
I'm hearing we have a couple minutes that folks can stay on if everyone's interested in finishing the conversation. Just want to hear from a couple more folks. So Jenn, both in the space of behavioral health and oral health integration and health equity, how can value-based payments support provider efforts to support those?
Yeah, so a couple things. I'll maybe make some comments around integration first. So we have established a population health management team, but that's only one step. What we're really having to do inside our organization, in addition to outside, is bring together providers, bring together the leadership that supports the providers, the care teams, which are much more than just a doctor. There's many pharmacy and other folks wrapped around a provider, and the contracting team together to actually come up with the models that we deliver care in and the metrics that we desire to have in our value-based contracts. It's super new work for everybody. People didn't used to come together and sit around the table saying, what can we do well? What do we need to do well? And how do we need to change? And that's why it's so important, getting back to my earlier comments, that we get to scale. Director Allen mentioned that there's differences in all these metrics. We need to, as a system, know what we should be asking for and try to bring consistency across all of our contracts around metrics selection. That's the only way to get the whole team engaged. So, and it sounds simple that we're just trying to do this stuff inside of our own organization, but it's really hard. And it's even harder when you're doing it as a community. As it relates to health disparities, what I would say is we view value-based arrangements as a way to force us to think broader about our members, to think about total cost of care. And those arrangements have to be structured so that we're incentivized and allowed to make non-traditional investments that can impact health. And one of the challenges we have, I think we all have, is, well, how do you measure the value of those non-traditional investments? Because we're all used to processing healthcare claims. And so we also have to think about, how do we do that with partnerships? For instance, in Central Oregon, we have the Central Oregon Health Council that makes a lot of the community-wide investments upstream, but also as a nonprofit, what are our community benefit efforts? And then at the basic foundation, we really have to work as a system to understand, what do our members need? What are their systemic and unique factors that impact their health? And then we have to be incentivized to do that work, which is not sick care. We have to be incentivized to do things differently. And it's taking time and experimentation and a little trust that that this is going to produce better outcomes. I'm sure it will. It's just a long road.
Great, thank you. Chris, do you have anything to add about using value-based payment to further the CCO 2.0 goals of integration and achieving health equity?
Well, just on health equity, I do want to make a quick comment. We've gone through quite a revealing experience around health inequities in the state through the coronavirus pandemic, nationally and here in Oregon. And I think what it has helped us at OHA understand better is that health inequities are far, far broader than the delivery of health through the healthcare system and the payment system. And that you can't deal with them if you're not willing to tackle the fundamental multi-generational impacts of racism, oppression, slavery, genocide that have accumulated and show up today in economic choices, housing choices, access to healthcare, ability to be victimized due to citizenship status. All these things today play out in how many people get sick and die from COVID. And I think as we move through the pandemic and think about not just value-based payments, but all of our systems around how to achieve what is now our agency goal of eliminating health inequity by 2030, we have to tackle those issues head on, not as a sort of a byproduct or a secondary feature, but as the primary job of trying to reshape all of our payment and other systems to try to incent changes in that system.
Really powerful. Chris, it looks like you get the last word on this topic.
Well, I don't know that I have anything really more to add. I would just reiterate, especially having been on the provider side for so long, to the comments earlier, you really have to look well beyond the outside of the traditional healthcare system to really attack social determinants and to eliminate health equity. I mentioned earlier investments in telehealth. That sounds great, but you probably need a smartphone, and you probably need internet access and Wi-Fi and everything else that goes along with that. So, you have to really continue to look deeper and deeper and further away from the care process to really get to those root causes. And as was said earlier, you have to embrace that. And, I just, again, remember being on the hospital side, and there was a lot of things that suddenly when value-based payments or pay-for-performance came out, you thought, well, how are we possibly supposed to be responsible for these things? The reality of it is we are. If we do want a effective, high-functioning, affordable, and sustainable healthcare system, then we're going to have to stop ignoring these things and embrace them.
Very true. Well, thank you all so much for joining us on this panel today, and thank you to Samantha and her team for putting together this conference this morning. This concludes the CCO Oregon conference, and I hope we all get to come together in person next year. And thank you all for attending and all of the work that you do.
Thank you very much.
Thank you.
Thank you.